Good morning, everyone. I think we're going to go ahead and get started while people are still checking in because we have a chunk of information to go through in a relatively short period of time. So let me start by introducing myself. I'm Nancy Snyderman. I'm a head and neck cancer surgeon by training. I live in Princeton, New Jersey, and I also work for NBC News as the chief medical editor, and I'll be the moderator of this session. We are going to do audience interaction, so there'll be some questions I'll be posting to you, at which point we'll be asking for your feedback. And we also have some microphones in the auditorium, so we may be going like this so we can see you guys. But if you'll raise your hands, we will get a microphone to you so that you can ask any of our people on this panel today any questions you might have. We want this to make this as interactive as possible. So I'm going to start away from me and introduce Sally Oakham, who you may have heard earlier this morning. She's with an extraordinary group. She's the vice president for Patients Like Me, and is in charge of patient and policy and patient safety. And if you don't know anything about Patients Like Me, I would advise you to get on the website today. This is one of the most disruptive, in all the right ways, nonprofits that saw the future before any medical center saw it, before nonprofits saw it, before people thought there was a way to make a buck off of this, but disruption for all the right reasons. And it's always been one of my favorites. Sitting next to her, Judith Hibbard, who is the professor of health policy and Department of Planning, Public Policy and Management at the University of Oregon. Extraordinarily brilliant woman who looks at policies in a way that most of us who've probably been entrenched in medicine haven't for years. And next, a fellow physician. Carrie Nelson is the medical director for special projects and an advocate physician from Partners and just up the coast from me. And then sitting next to me, a gentleman who has crossed paths with me, but never at the right time. We seem to have job ADD and always quit the same jobs as we're heading to different places. Mark Gelbert, who is with Pfizer, who I must say is also underwriting this session today. He's the senior vice president for global R&D, and he runs a very innovative process, which doesn't sound innovative on the surface, but let me tell you, having worked for Johnson & Johnson and for General Electric, the idea of taking products that are behind sort of the walls of the inner sanctum and getting directly to the consumer, that is game-changing. So I'm going to scoop back a little bit. And I've asked everybody to sort of chime in, and I want you guys to too. But let's start with the basics. I want to start with my fellow doctor. You and I grew up to believe and just pretty much be trained that as physicians, we know a lot, if not know all. Patients can be too hot. Patients can be invited into the system, but we don't necessarily invite them. We certainly don't automatically hand them their medical records. And many times when asked, well, what should I do? Our fallback answer is, well, if I were your mother, or if you were your sister, and then we sort of go like that. The idea that the patient would suddenly be a consumer has for a lot of people connoted kicking tires, and it's made those of us in medicine go, ooh, 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 that's not what we do. But in fact, you and I are right on the precipice of watching game-changing phenomenon in this country. What have you seen?
Well, I'm a part-time clinician and a full-time or relatively full-time administrator in a large health system. So I get to play on both sides where I have the personal experience with patients in the office and the kinds of interactions that I'm seeing change. And I'm also having the side of seeing my physician colleagues try to adapt to those similar experiences. So.
And Partners has been transformational. I mean, it's been a complicated system in a complicated city doing pretty innovative stuff.
Right. We are really right out there on the front of the curve and really looking at how we can be more disciplined about engaging patients more fully in their care. And that will be a cultural challenge for us from our physician's perspective. So in my own practice, I see patients that come in with information. Sometimes it's good information, sometimes it's not so good information. And in my, I'm one of those that really got on the bandwagon of patient engagement probably about 15 years ago, post my training. And when I see a patient like that, I get excited. I think I've got a patient here I can actually work with. They're thirsty for knowledge. Let's jump in and start seeing how we can collaborate fully. And I hear my colleagues say something quite different. Oh boy, when they bring out that big printout from the computer, from the internet, I get, where am I going with this? And can't you just come to me for information? And so we've got a tremendous cultural hill to climb to be able to have our physicians behave in a way that embraces that changing consumer attitude in patients.
Judith, I saw you shaking your head.
Yeah, Carrie and I were talking about this earlier. It is a big cultural change. And if it's okay, I'm going to just take a minute and talk about my work and how it relates to this.
Absolutely.
So I was really taken with what Andrew Soley said about if we can't see it, we can't fix it. Because that has been my experience. About 12 years ago, I was involved in a lot of the information for consumers and realized that a lot of people don't go there. They don't seek this information. They aren't interested in really engaging. And so that interested me. Why are some people really proactive about their health and others just really, really passive? And being the pointy-headed academic that I am, I thought, I wonder if we can measure this. Because if we can measure it, then we really can understand where people are on this dimension from really passive to really proactive. And the Robert Wood Johnson Foundation thought that was a good idea and funded us to do that. And that was, as I say, about 12 years ago. We did develop a measure. And since then, for me, it's been like putting on a new set of glasses, and I look out in the world and I see everything different. Because I see that in most population groups, you see this full dimension of people very passive to very proactive. You see that people who measure high on our scale, which is called the patient activation measure, they engage in more positive behaviors, they have better health outcomes, they actually cost less. And now health systems are using this information to tailor how they interact with patients. But one of the early aha moments for me was we did a study and we looked at how the Stanford Chronic Disease Self-Management Program helped people. And yes, it did help them to become more engaged, but we saw that it was only the more activated patients who showed up. And that was like a light bulb for me, like, oh, I bet everything we offer, it's the more activated patient that shows up. So there's been a lot of aha moments along the way, but we've learned a lot, and probably all my comments are going to be looking through these lenses.
That's okay, because that raises one of the first questions, the audience interaction question, and that is, are you starting conversations about your health with your doctor more than you have in the past? One answer, it's about the same. B, no. Or 3, yes. What do you guys think? So are you starting conversations about your health with your doctor more than you have in the past? In some ways, I think it's almost a nuanced question. I think if it's sex, happiness, depression, the answer is probably people aren't speaking up. And there you go. In this audience, people are speaking up more. Do those lines surprise anyone?
Well, I can tell you, we actually asked these same questions on our social media outlets for patients like me in anticipation of the panel, and also posted it in our forum for people to go to our blog and respond. And we actually got 200 responses to this question as well as 2 others, and they're actually quite similar. So 50% of our respondents said that yes, they were, and then about 10% of them were saying no. But the one thing about this question that I thought was rather nuanced, for those people who are doing it about the same, it's sort of hard to know whether that sameness is that they actually are engaging, or that sameness is that they never did. So it's hard to know exactly whether or not this is a group that's actually having those conversations. I suspect with our population of patients, the likelihood is that they may have been having conversations about a year or so ago or in the past, and they're still doing the same. But I think we still have to answer that and kind of dig into it a little bit deeper. But I think that this is an interesting population of people we have here.
Right.
And still for some to say it's about the same, I'd like to kind of figure out whether that's because the sameness was because you were still doing it, or the sameness is I never did it.
So if you were going to change that question and just nuance it a little bit, how would you ask that? So let's just say, are you starting conversations with your health, mental health, sexual health. I suspect there are some things that are absolute burdens right now, hurdles that we aren't discussing.
Yeah, and I think that the questions are skewed a little bit because of the audience that
Sure.
we have here. And I'm not sure that it's as much a cultural change as you think about, maybe on the healthcare professional side, but not on the consumer side, because, and I'll use the term consumer or people, because we've talked a lot about patients, but before you're a patient.
Well, let me stop you for a second. Should we get rid of the word patient? I mean, does patient connote illness, and consumer connotes someone who's active and engaged? And the reason I ask is because Dr. Sievert Koop, who is a very good friend of mine, was adamant that we not call people consumers. He thought that those really were people who kicked the tires. And I believed him because I followed him and loved him, but I now think he was wrong. And that was sort of the old model and allowed us not to move forward. So as you sit here as someone who's absolutely in the consumer space, should the word patient be for someone who's sick, or should the word patient go away?
I don't think it should go away. I'm not sure it should be used for sick. It's definitely when there's an interaction between, you're a consumer all the time, but when you're interacting with a healthcare professional on a matter of your health, that's when you may become a patient at the same time as you're a consumer. But you're first and foremost a consumer, and it's the consumer that first and foremost feels something different or sees something different or senses something different that motivates them to act. And that action may be to talk to somebody, as the survey question here asks, and I don't think it's most often the doctor. It may be a conversation with a family member, it may be a conversation with a friend, it may be a conversation with the internet nowadays, and then it motivates you to act and do something. And the first opportunity, the first entry into the healthcare system, typically, if it's not an urgent situation, is self-care. And so I don't think it's a big change culturally. That's been happening. I think it might be a bigger change for the healthcare professional.
You know, it's interesting. My colleagues and, you know, even I struggle with trying to come up with a different term for that role.
It's a weird, it's a really weird, it's like there's nothing in the middle.
Right. Well, I think what it is, and I so appreciate what Sally said earlier about the value of language. Whenever we start to really change something dramatically and change our mental model of it, we may need a new word for it. And I think that's what we're struggling with.
I agree.
Is a patient has a definition that now feels archaic.
Yeah.
That is, I mean, the traditional definition of a patient is someone who is passive
Yes.
and does just what they're told. And that doesn't really fit anymore. But I'm not
what's
sure
the
that,
right
I'm not
substitution?
sure that
I think that's the
consumer
root of the
fits.
word, isn't it? Patience, right? You're passive, you do what you're told, you listen to what the physician says.
When I hear patients like me, it's like, well, I certainly don't hear passivity.
Yeah,
That's
no,
true.
no,
That's a
and
good
I
point.
think, you know, the mental model of words for me is just fascinating. So, you know, the reason that we use doctor in that question, and we use it somewhat frequently on the site, is that when people talk about going to a healthcare provider, they don't say, oh, I'm going to go see my nurse practitioner. In fact, they probably are, but they're going to
Right.
the doctor's office. So I think we tend to sort of lean towards what are the words that patients are using, what are the words that people use when they're encountering the healthcare system. And they typically kind of think about themselves in ways that when I'm encountering the system, I'm a patient of so-and-so's. and I'm
Because
going
of
to
you
the
now, I
doctor's
want you to know I'm going to use the word ravel.
Ravel,
all the
there you
time.
go.
Who knew?
You know,
I mean, I was backstage going, ravel. I was like, stunning.
Isn't that?
Isn't it
I know.
stunning?
I love words.
It really
I love.
is.
But you know, I posed the question to my husband recently because he encountered the healthcare system for the first time about a year ago, and it was a serious incident. And he's now quite well and doing all right. And I said, "Do you think of yourself as a patient?" And he says, "Absolutely not." He said, "I have heart disease and I take medications, but I don't think of myself as a patient. I think of myself as a patient when I go to see Dr. McGowan.
It's the
that's,
role.
That's where I am. The transaction's taking place, and then after that, I'm a person who's got this. And I think that's the other term that I think that I would probably suggest we think about and define, because it's been defined, I think, in people's perceptions, is e-patients. E-patients actually indicates you're empowered. There's a number of other E's you can add to it, like electronically connected and that sort of thing. But empowered patients are people who have a reason to be encountering the health system, but they're empowered enough to take on the self-care roles that we are expecting, and maybe are going to be higher on the activation level that that Judith is measuring.
So question number 2 for you guys as we move along. What percentage of adults employed full-time consider health to be important but find that other things take priority?
That's a great question.
This is a good question for everybody in this room. How many of you think that other things take priority over your health, even though you know that health is important? And as we get those numbers up, before we put the numbers up, I'm going to ask you guys, because I know who the question came from. Where do you guys think the number is?
I'm going to say probably half, about 49%.
Yeah, that's the correct answer.
Is it?
Is it?
Yeah, 49%.
I thought it was even higher.
I would have, it's
Yeah.
funny, when I looked at this ahead of time, I picked C. I thought 63%. I thought it would be more than
And it seems that
half.
everybody else thought the same.
Yeah, I really thought it would be more than that because it's very easy. And, personally, it's easy having a national soapbox where I get to tell people what I think and what to do. But it's much different when you go home and you realize you haven't eaten dinner that day and should you eat, and you've got elderly parents, et cetera, et cetera.
The key here, you want to know what the key is? Employed full-time.
Yep.
They get health benefits. They have to think about what does it mean when this explanation of benefits comes in the mail and I can't read it and understand it. So the things that are on their mind about the kinds of things that they have access to are different from people who are not employed full-time and don't have access to insurance. They're thinking about it in a different way.
So as we sit here on the eve of the Affordable Care Act, and we try to figure out not only what does it mean, but state-to-state implementation, if I'm working 39 hours a week and I might not have full benefits, this might well be 63 or 86%. Especially if I'm holding down 2 jobs
Oh,
and have
you
3
better
kids,
believe
et cetera, et
it.
cetera.
Yeah.
Selective perception. It's a sort of sense of being able to say, well, how am I prioritizing the things that I have some control over? Well, if I don't have control over them, getting access to good care because I don't have good insurance or any insurance, then it comes back down on the priority level. And we heard that yesterday. 25,000 people are dying of things that could have been prevented, right? So it's that population of people who we're not reaching because it's not a priority on their mind because we haven't made it a national priority to take good care of them.
Let me ask you a question, then I want to open this up to the audience. So start to raise your hands, and we will get microphones to you if you have a question. When people on the street turn to you guys as experts in the field and ask you what's going to happen this fall, explain healthcare reform, can you, seriously, explain it succinctly? And if so, what do you explain? And I'll start with you, Mark.
Well, I certainly think I can explain parts of it succinctly, certainly not I think I remember seeing a commercial a year or so ago talking about a 900-page tome of the Affordable Health Care Act. But I think to me it means more people getting access to health care insurance, more people subsidizing health care in the United States, skewing a little bit younger to enroll so that the economics of it work. And I think the fear that I hear most often is the lack of enough primary care physicians available for this new group of patients or subjects.
In fact, you've
coming in.
punched those numbers, looking at how many.
We've looked at the number of reports that are out there, and it's a significant amount of physicians that I think they believe will be gapped at that time.
So let me ask you a question, because that raises a very interesting sort of bias I have about physicians. Are we looking at a physician shortage because there aren't enough docs? Or are we looking at a physician shortage because physicians have been a little late to share the goods of how we distribute healthcare in this country? Should there be more nurse practitioners, physician assistants, even people in the field who can be trained to do certain things well and report in just on that thing that the University of Arizona has done very well?
I would have to say a resounding yes. I think, as was talked about yesterday, we need to redefine care and we need to redefine caregiver. And we need to understand that there are certain things that can be done at different levels of understanding and involvement. And I think that we also need to start thinking about the people who are not currently being considered as sources of support for the new emerging population of people who are insured are people for whom we don't have reimbursement methods. So thinking about who gets paid in the system is typically where you try to fill the gaps. So you're either going to fill it with physicians or potentially nurse practitioners because they have a revenue mechanism. But what about health coaches? Where will they fit within this model? So I think we need, and some of that will get taken care of in the capitated rates that are going to be a part of what are called accountable care organizations. Actually, I got to throw this word in here because it just fascinates me. Does that mean that other organizations are not accountable?
Probably.
So a resounding yes for me.
So one of the things that I worry about as this rolls out is people who haven't had insurance or they haven't had a lot of experience with this, going to the exchanges and being able to make sense of their choices. And understanding all the words that are, the technical words that are associated with making insurance decisions. And presumably they're also going to get comparative quality information. So this is going to be a new challenge for folks, and if the exchanges can make that information really usable and digestible for these new people entering the system.
Despite or in spite of how smart the four of you are, don't you find November a daunting experience when you have to sign up for whatever you're supposed to sign up for? I glaze over. And then to try to figure out how much you should put in the kitty for next year for how much sick you might be.
Exactly. How about the rest of you?
It's true, there's no doubt.
Yeah.
It's crazy. So, I mean, for people in the system who think they sort of know their microcosm of the system, to plan ahead, I mean, everything's so fractured, I'm not so sure there's an easy fix to sort of put all the pieces back together. But another question for you in the audience. And I'm going to, this is in order. What percentage of consumers have looked online for health information in the past year? 8, 23, 40, or 59%? This comes from Pew Internet and a study in 2013, and very good data. And frankly, I thought this answer was low.
Yeah.
So the answer is everybody punched in? There you go. So everybody picked D,
I
the
picked-
right answer.
yeah. Okay.
I
You
would have
was
thought
lower?
it was 80%.
Oh, I
Higher.
see. You thought it was higher than
I
this.
would have thought people, I mean,
Sure.
everybody's looking.
Well, the difference
Yeah.
is the Pew Internet study does, I think it's about 80% of US consumers are online and most frequently looking for things, and their transactions online are typically emails, doing searches for a variety of things, and then health is very high on that list.
Well, I think you're too nice, but I think porn is up there.
Well,
And gambling.
But I think, I mean, really.
An Angry Bird.
Yeah, exactly. Then you come down to health. It's like,
Exactly.
yeah, I mean, that's just the truth, folks. It's just the truth. I mean, we're here to talk about the truth. Any questions out there? Do I see any hands? Yes. May we get a microphone down here to the third, right down here to the
maybe
the
you could
beautiful
stand
woman
so
in
they can
maroon.
see.
If you would please stand.
There you go.
And if you would please say your name and where you're from, that would be great.
Hi, I'm Arkel Giorgio, and I'm a physician and a Fox medical expert. So- and I enjoy watching.
Disclosure.
You know, I'm really intrigued by the fact that all of you on the stage were struggling to find a better term than patient or consumer. And yet, whenever we are consuming other things, whether it's a hotel reservation or a restaurant or going to church, whatever it is that we're doing, we don't need another name when we're actively pursuing it or not actively pursuing it. So here's my question. Do we need a new word because the traditional medical establishment needs to have a new word to separate them from who they're serving? Or do we all collectively as a population need that word? Who really needs it?
See, this is why you're on TV.
Right. So it is a great question, and sitting through the conference over the last couple of days, Arkel, you were the first one that really didn't use the term patient, and you were the first one to really ask the question, how do you define care, in your discussion yesterday. And I think that's part of the problem, is we get caught up in patient, doctor, hospital, emergency room, healthcare system, and we forget, again, that it all starts with an individual who senses that something is wrong or chooses to want to do something right about their health. And I don't think we need to change the terms for the consumer, but if we're going to alter the system and make it more user-friendly, consumer-friendly, more simplified, as this Transform conference is all about, I think we need to get the healthcare side of the system to be thinking about the individual as an individual first, as a consumer second, and then maybe as a patient, because patient is the last thing. You want to be an individual first, consumer second. You don't want to be a patient.
And I think, you know, if you look at other examples of how we have reoriented our language. So for example, instead of calling people mentally retarded, it's mentally handicapped or cognitively disabled. It does help you reframe how you see that person. And I think that it does become part of an old vernacular that keeps us feeling a little bit stuck if we don't evolve. I think it may be for the medical establishment more so than for people that we change the terminology, because we need some good tools to advance this culture. We have a long way to go.
Jude?
So part of the problem I have with it is that it's them, it's us, and really I think we're trying to get to a place where we understand the patient has an important role to play. They are contributing. They have lots of things that they need to do, and we need to think about them as on the team. And so they're not just consuming, they're part of the process. And so that's why the consumer label I don't really like, and I don't really like the patient label, but I don't have a better.
Yeah.
But you
So
know,
maybe
it is
stuck with it for
interesting
now.
because, you know, and now this is just with my surgeon brain on, but, you know, surgeons come through practice and it's a training, and this is nothing to brag about, it's just our reality. You know, you'd easily say, you know, the woman in 514 bed 2 with a liver tumor, blah, blah, blah. That person never got a name and that person never got a description. It was always the liver tumor patient, the heart attack on the 5th floor. And we described people according to the malady. So as I'm listening to this conversation and thinking about your point, I think we've taken people and we've plugged them into the system that works for us individually. And as medicine has become more fragmented, I've wondered if we sort of struggled for our own term. But consumer, I agree with you, Judith. Consumer, it isn't quite
Doesn't
right.
resonate,
And
yeah.
patient is too passive. You're, by definition, I think, already sick.
Yeah. And basically, we're all patients. We're all people. We're all patients. And yet, when you think about, you know, the medical environment as a stage, you have various roles. You have a physician role, a nurse role, hopefully a health coach role, maybe a social worker, and you have to have some kind of name for those different roles.
And I feel the need to reframe this a little bit. The reframe is actually, we're people, and we all have a health span that exists within our lifespan. And so that at any point in time across our health span, we may find ourselves in the company of people who are delivering care to us, or we're participating in some sort of exchange with them to get something that we need to be well or to live with illness. So I think all of us in this room should recognize that we all have a health span, and at any given point in time, where we are on that health span is going to be influenced by our wellness or our introduction to illness or our introduction to disability or other kinds of issues. So I would love to see each one of us think about our own picture of health at any given time and watch how that changes over the course of our life and understand what that means in terms of our decision making and how we start to prioritize and the different modifications we have to make as we transcend through these different places on our health span. Regardless of whether you call me a patient, a consumer, or a person, I think the more important
like
piece is
Person,
we
yeah.
need to figure out as a society that we're all going to have to deal with some illness at some point in time.
And I do think that during that span that you talk about, consumers, for lack of a better term, can engage in their health without engaging with a healthcare professional.
Absolutely.
And that's what we're talking about. In
Absolutely.
fact,
sure.
most
That
of their
span
life,
is-
you are interacting with products and information and actions that don't relate to a
You take on
healthcare
your own
professional,
or with someone
where you don't
else,
see
right.
yourself as a patient, you see yourself as an engaged individual taking action on something that you want to
Yeah.
improve.
So
Hold
this is
that-
all of us. It's
Hold
we.
that thought, because I want to go, I'll come to you in a second. Yes, ma'am. If you would
Yeah.
please stand up and tell us your name and where you're from.
My name is Chris Johnson. I'm a nurse here at nurse administrator here at Mayo Clinic, and it just seems that, simply put, in my own mind, if I frame it as we as caregivers, we really have an identity crisis ourselves, and this is a very big cultural change for us that involves our own identities. And we need to talk about it more and really come up with what are some of the spaces that we need to offer between or with, and how we work with our patients, clients. It's a lot about our own ability to know where we are coming from and what we have to offer and feel really sure about that. So that's just my
Great,
comment.
great observation.
I think that is a really important point. If we step back and we say, well, what is engagement? What are we trying to achieve with this? And really, it's about individuals taking more ownership and feeling more in charge. And what we do in healthcare sends lots of messages about what we as caregivers think the patient's role is, and shapes those expectations. Now, if we think about helping people to be more empowered, what is it that we can do different in our day-to-day interactions that make a difference? When I look at sort of what do we do, at one end, we expect way too much from patients in certain situations. And at the other end, we miss a lot of opportunities to let people do more and be more involved. And I think we need to sort that out. And part of that is understanding what your job is. And this is something that in my work I come up against all the time. Sometimes doctors say, hey, that's not my job. But yet, doctors are being held accountable for things that patients are essentially in charge of. You know, whether they take their medications, whether they show up, how much they follow good diet and exercise. Those are under the patient's control. What can clinicians do to help them make those changes?
There's that word accountable again. And I think that, yes, and in terms of some of the questions you were asking about the ACA, within the Advocate Health System, we are very much involved in some of these accountable care organization strategies with Medicare, soon to be Medicaid, and currently with our largest payer. And we hear exactly that. We hear, you know, physicians are being held to making sure that patients follow through and get mammograms and follow through and, you know, do certain things. And we have this judgment when they don't called non-compliance, which is still very much, unfortunately, a part of our language.
Almost as bad as when patients don't respond to the chemotherapy and we say they failed their
Yeah,
chemotherapy.
right. It's as if we need a new compact.
Yeah.
We need a whole new compact of what it is, what this relationship looks like going forward. And we have, just one more point, we're all so excited.
I know.
We have eroded the trust in folks by not allowing them to play a more active role and by placing that blame and that judgment around being non-compliant. That erosion of trust creates problems with believing that journal article about MMR causing autism.
Right.
And so we've got to take responsibility for that and behave differently.
One of the things that's striking me a lot lately is the use of team-based care. And I actually had the privilege of working on a project with the Institute of Medicine a couple of years ago, writing a paper on the values and principles of team-based care. And it was really interesting. By the time we finished, we realized that we actually never asked patients what they thought about team-based care. So the second step of this project we're in the midst of doing now, and we're actually saying, so what does it mean to be a patient on a team that's delivering team-based care? Do patients have a role? What are their roles? Do we tell them what their roles are?
Do they like
have
their roles?
responsibilities?
Well, and some
Do
of
they
them-
accept? Because if you think about the values and principles, they are shared trust, and I'm accountable for my role. So if the patient's going to be a member of the team and they're really at the center of it, well, then we damn well better give them some instructions on how to be a member of that team.
We have a microphone back. Yes. And then if you'd please get it to the front row after that. Oh, yes. Sir, gentlemen, if you would please stand up.
My name is Rick. I'm a designer from Grand Rapids, Michigan. And just 3 quick data points maybe, and then you can reflect on that. You talked about the health path and taking accountability. So in design work, I purchased a Withings blood pressure cuff. I just wanted to see how it worked. And started taking it and started realizing that I think my blood pressure's high, finding that out. I've gone through 23andMe, and I also diagnosed a broken thumb using Health Path. So I've used some of these tools, and what I'm finding, like with this blood pressure, is what do I do with it? And who do I ask? What I'm finding is you say take responsibility or do all these things. I actually feel a lot of people are doing that. I feel there's a gap between the information, the data that I have, or the questions I have, and connecting that to you guys.
Absolutely.
And finding that intersection.
Yeah.
So that's my point or question.
And so here's a healthy young man who, if by the stereotype, is opting out of any ACA payment, not worried about anything, suddenly wants to engage, and boom, engagement's not so easy.
It's not so easy. And in fact, even bringing that information, that data to a clinician and saying, having them think it has some veracity to it is actually questionable too. So it depends on your clinician. But I would encourage you to think about tools. And I'm just going to say, like patients like me, our goal is actually to have people think about what their health span is, create a picture of health for yourself, and actually start to monitor things that right now may seem just a little bit off. But at some point, if you're continuing to monitor, you'll be able to see things in a different light, and then bring that to the ongoing relationships you have with your clinicians. But you're right, we're gathering data, and we're not necessarily helping people have a good sense of what to do with it. So,
I think it's fascinating because you talk about gathering data. You have tools, and when you think about self-care, again, it begins with your ability to learn something or know something. And Judith was talking about the healthcare practitioner understanding where they can let go and where they can't. And I remember very early on in my career, one of the most fascinating debates I ever watched was back in the early 90s at an FDA advisory committee where a company, pharmaceutical company, was trying to switch a product from RX to OTC, and that product was gynolotrin. And the debate that went on at the advisory
Women will
committee
never be able
as
to
to
do it,
whether
right?
a woman could self-diagnose or self-recognize.
Her own yeast infection.
Now, what was truly
Oh
fascinating
my
about
heavens, how could we?
what was truly fascinating about the debate was the male doctors on the panel versus the female doctors, number one. Fascinating, but then also the resolution that occurred in this conversation when you talk about what do I do with the information. The problem that the FDA had on this during this conversation was, well, a woman really can't diagnose it because it really takes a culture and an understanding of signs and of symptoms, but she could probably recognize it after she's had one, and she knows she's had. So let's put self-recognition on the label, and now we can let this consumer take advantage of it by herself. So again, fascinating debate between what the physician thinks a consumer can do and understand with the information or the sign or the symptom, and what the consumer believes they can do. And obviously, to many of you in the audience, many younger people, you probably don't even realize that before 1990, you had to go to a doctor to get a prescription.
And you wouldn't get it that day.
And you wouldn't get it that day.
So this is a perfect segue into our next question, and then I want to see hands raised, because remember, the guy sitting next to me also brought you KY jelly in lubricant form for sex. So no longer necessary for rectals. You too can have it for sexual intercourse. So.
She knows a little bit too much about my background.
And I'll be damned, you're blushing. Who would have thought? Yes, KY is warming. So here's your next thing. After nicotine replacement therapy became available OTC, how many, over the counter, how many additional smoking quit attempts were there annually in the United States? None, 25,000, 175,000, or 3.3 million. And this is data from 2010. Of course, now we know that you can get nicotine by gum, by nose spray, and of course the famous nicotine patch. But for the audience, how many people do you think tried to quit smoking after nicotine was available? And remember, nicotine doesn't kill you. Nicotine just addicts you. So, audience, because I'm not going to step on this one. It's too cool an answer. Smart audience. Over 3 million.
It is amazing. And
the power of getting products into people's hands.
Right, and access is very important. First of all, it has to be the right kind of a product.
Right.
It has to be something somebody self-diagnosed. It has to have a safety margin that if it's misused, it's not going to cause significant problems in an urgent way. But I think what's really important here in this particular one, and Nancy, you mentioned it earlier, there's a sense of motivation and timing that plays out in these situations. When you want to quit or you're ready to quit, if you've got to call the physician, make an appointment, talk to them, get a prescription, the moment's passed. Right. And here's a situation where access, the benefit of access, far outweighed any of the potential risks of having, I think that at that particular time the concern was the youth market getting a hold of these gums and getting addicted to nicotine gums. They don't want the gums; they wanted to smoke.
Right.
And but ultimately, this is probably one of the biggest advances on a self-care side that has had a huge impact on the population, on health, on healthcare costs, and we need to see more of things like
Well,
that.
it's interesting. I think I've been around just long enough to sort of see these waves. When HIV, home health HIV kits came, the argument always, well, oh no, nobody can handle the data, that person will commit suicide overnight. Well, no, not really. People just wanted to know their HIV status, and now it's sort of the norm. And so there's always this hurdle like, and now 23andMe is going with this. There aren't enough trained geneticists in the country to sit down with every person who wants to know what he or she may be at risk for. So people are taking control of the situation and saying, look, you may think I'm not smart enough to handle it, doctor, nurse, whatever, bye-bye. I am smart to handle it. And increasingly the disruption is going to it's going to be a marketplace-driven disruption, frankly, for all the right reasons.
Right. Excuse me, I think one of the things that we try to drive home is that the opportunity to engage at any time you want on your computer and to put in information that's meaningful to you, that you want to monitor over time, is a motivating factor for you to take some charge of what's happening to you. So if they had to wait and call a physician or a nurse practitioner or someone else the next day, when in fact at 3 in the morning they're trying to figure out, why can't I get to sleep? What is this insomnia about? Are there other people like me that are dealing with these issues? Those are opportunities that we can't lose. We have to take advantage of them. So our responsibility as designers, as people in healthcare, we have to give that access some meaning, give them back something. We have a mantra at Patients Like Me that if you give us something, you get something. So we don't take any bit of data without giving you something back, whether it's in a graphic display or some other thing that says, gosh, did you know 150 other people reported that same thing in the last 5 days? You want to see them? Do you want to talk with them? That sort of thing. So giving people the opportunity to have access, to inform it in some way so that it makes some sense to them, and then giving them the opportunity to act on their own. With always, our advice is you have the opportunity to always take everything you're learning to your clinicians and work with them in ways that help you participate in that care, not necessarily be the recipient of that care.
We have a question.
Actually, my name is Meredith, and I am in the Center for Innovation, but the hat I'm wearing for this question comment is from being a chronic patient. And I've been a managed chronic patient and unmanaged chronic patient, so I've had a lot of experience with the healthcare system. And I think one of the things...
Can you share what your underlying issue is?
I have migraines, severe migraines. And one of the themes of this conference that I'm taking away is trust. Trust in the community, and people have talked about the interrupters, the messengers, the new roles that will go into the community and build trust with people. And when I hear the word consumer, I don't associate that with trust. And I think at best, the people who provide my services to me that I pay for, I might have brand loyalty, but I can't think of one that I have trust in. And I just wanted to make the comment that I heard the word up on stage that completely resonated with me, and that was partner. I mean, if my institution or my providers, if everybody started calling me a partner, I would feel really empowered. And I don't know how other people feel about that. And I guess the question maybe, if there's a question around the comment, is do you think that healthcare in general can see for patients and change reframe them into really partners?
Well, I'll let the person from Partners answer that. So.
Advocate physician partners, right? Well, I do think that it's possible, but I'm also a little bit of a dreamer. And that's why I think we're all here probably good, we'd be qualified as dreamers. But it's going to take a long time. It is. And I think we have to really work hard on it. And from the medical perspective, we have to almost go overboard to convey our willingness to partner, because our patients are so unaccustomed to that attitude. I mean, I had my 95-year-old grandmother, I said, about a year ago, you're going to get your flu shot? And she goes, yeah, but I want to ask my doctor first if I should. And I said, please don't get the flu shot.
Are you chopped liver?
Yeah, exactly, right. Somehow she might be special and she shouldn't get a flu shot. So she waited until January to go in, and that was just wrong. And it's almost as if we have engendered such a dependency And that trust was wrapped up in that dependency, and now we need to even redefine what we mean by trust. It needs to be this partnership type of.
So can I turn this a little bit on its ear for a second? Because, you know, I get invited to a lot of medical conferences, and I meet a lot of smart people, and I look in this audience, and everybody's smart, and everybody's here for their own reason. But institutional trust has not been the norm for African Americans. And for people who make hardly any money, the idea of shelling out what you don't have to go see a doctor for preventive care is not something. So if we're really going to move things forward in this country, we can't leave race off the table. There has to be some way we turn this around and address the fact that Tuskegee is still in people's minds. And Henrietta Lacks is alive and well in people's minds.
And alive and well in many of the medical answers that we have today.
Yes.
You know, I'd have to say in response to the previous question, which I think was an excellent one, the drive needs to come from patients and people themselves. We need to be the ones who define what we want to be. And each one of us, as I've said before, we're in this together. Even though, I have a medical issue that I have to deal with, I don't think of myself as a patient, but I do think of myself as a partner with the people who are working with me on managing it. But at the same time, I think it ultimately is not going to come from the institutional environments. The Center for Innovation is a really interesting place, and it's doing some wonderful work, but it's a pocket. You know, we as a population are the ones who should be driving what it is that we want this to be, and not allow institutional and organizational settings to set that agenda for us. So I just can't emphasize that enough. Each one of us either are experiencing healthcare issues that we deal with ourselves, or we're working with a family member who is. Empower yourselves and figure out better ways of being able to communicate and participate as a partner, as a team member, whatever is comfortable for you, and then I think that will start to rise. But it's going to rise from those of us who are actually receiving the services or purchasing the products, not from the institutional entrenchment.
Judith?
Okay, I'm going to put on my patient activation lenses again, and I'm going to tell you about what we learned when we looked at people who were less engaged, especially people with chronic illness. What we learned is that people who are very passive have had a lot of experience with failure. They have tried, they say things like, it doesn't really matter what I do, I can't have a positive impact. They say, I'd rather not think about my health. They may not really understand what their role is.
And is this everything, is it obesity, diabetes, heart disease, cancer, you name it?
You name it.
Across all races.
Right.
Yeah.
That people who are less activated on this 0 to 100 scale, that they're more likely to be in this place. And so think about what happens when that person, and I'm talking about in some populations as much as 50% are measuring at this low end. Think about their experience in getting care. If they have chronic illness, they probably go out of the doctor's office with a big long list of all the things that they're supposed to change about how they live their life. And, you know, they might try to do it, but if they're already overwhelmed, they have little confidence in themselves, and maybe not very good problem-solving skills, they aren't going to be able to do all that big long list, which can involve a lot of difficult, complex behaviors. And the human thing to do is to not do any of it when you can't do it all. And so by not really understanding that not everybody is ready to be thrown into the deep end of the pool, which is kind of what we do with people now, we're setting people up for failure. So yes, I think if you
So let me just stop you there. So with the Affordable Care Act about to come, do you think we're going to be tossing people into the deep end?
I do.
I do too. I don't think we're prepared for the self-care needs that they're going to have in order to be able to get to the point that Judith is describing, moving along an activation scale that actually empowers them to think about I can do one or two things and I'm going to do those as well as I can. I may not be able to do all the other three of them, but let me have some successes and move forward. We don't have a system to support that kind of decision-making for patients and families.
And when people are unaccustomed, I mean, it's hard enough for people who are accustomed to working with the healthcare system to know how to navigate it. But for people who are totally unaccustomed and coming into this healthcare system newly, that navigation piece is going to be huge.
But it's very sobering to think that, you know, October 1st, we're going to have a paradigm shift, and instead of having people who are going to be more included, we're going to have more people slipping through the cracks. unintended cracks perhaps, but in cracks.
Yeah, I mean, one way that I think about this is that there are people who are very activated and engaged, and they go out and they seek information, and they're proactive about their health, and they get what they need from their providers. And then there are folks at this other end of the dimension. And by just leaving them there, we're sort of increasing the disparity.
But I think it's healthy to be a little anxious about what will happen when we activate the Affordable Health Care Act, but because that'll help us prepare to solve some of these problems. But to be worried about who may fall through the cracks when you're going to be bringing so many more people into the system and be able to help so many more people, I think you start there and build up the system over time to make it work, because if you don't activate the Affordable Health Care Act, you won't find the gaps.
Yeah.
Absolutely. I'm
It's gonna
not,
be
I'm not
messy.
arguing against it. I'm
It's
simply
gonna be
saying that
messy.
it's not going to be a panacea, that we're going to have all of these newly insured people and we're going to have them feeling like they are empowered enough to get what they need when they haven't in the past been able to really get access to what they need. So I agree totally. The opportunity exists. We need to seize that opportunity and make it actually happen for people by looking at new ways of defining care and thinking about who are we really looking to help support these patients
And I
in their
think you
care.
hit the name. I think how we define care and who gives it.
Incredibly important.
Yes, sir. I think it's on.
Can you hear me?
Yes, loud and clear.
I'm Gary Slick, and I spoke yesterday.
Yes.
I wanted to share just a couple things. As I was talking about yesterday, so we have this system where we're working with people who are very high risk, who are in the neighborhoods, who we continue to work with over time. And we were calling them, thanks. We were calling them clients. We're struggling with the same issue. And neither our staff or the people who we were working with liked the word at all. And we asked them, and they came up with the word participant. I'm not completely satisfied with it myself, but they seem to like it a lot. I think it's cumbersome, but I'm just sharing that we actually did ask them, and this is what they're feeling okay about. I guess partner is good too, but then there's this whole other aspect that I wanted to, that's where I was 3 minutes ago until Judith reminded me the real difficulty that patients or participants or anybody has dealing with the long list of what to do. And saying that we're trying to empower people is, it's insufficient for fully understanding how hard it is for anybody to change
Yeah, absolutely.
without hand-holding.
Absolutely.
And so, I ran the tuberculosis clinic in San Francisco years ago. We would send someone out every day to every home or street or whatever, just to ensure that they took one set of medicines.
Yeah. Yeah, and
The simplest thing possibly, just for that. And so we're needing to, the system, without this outreach component or continuous interaction, it can't work.
Yeah, I agree.
yeah. Well, and something, it might have been Sally that said it earlier, this notion of credible information from a credible source. That's exactly what your program does with Cure Violence. I mean, you have credible information coming from somebody who's from their own community they can relate to. And we need to, in terms of bridging this racial and cultural gap that we have in this country, need to access that knowledge a whole lot more.
But just to make this, this isn't only the credibility, it's continuous help.
Yeah, yeah,
Succeeding.
True.
To your point, everyone is failing
yeah.
and feeling worse and worse. And they need help to succeed. And then
Over
they
a period
succeed. Yeah.
of time, not just one or two interventions.
Yes, but I would amend that just a little bit. I think if you approach people who are less engaged, less activated in a way that, and you're thinking about this is about capacity building for that individual, that you start where they are and you understand it, just like learning how to swim. You know, it takes some confidence, it takes some practice. It takes small steps, and before, you know, people put their face in the water. And so if we approach people appropriately and build their confidence and their ability to manage, they'll be ready for the next small challenge. But we ask people to do this big long list, and we push them to do the most difficult behaviors right away, and it sets them up for failure. We need to set them up for success by breaking things down into smaller steps, even if those small steps are not clinically meaningful yet.
Can you give me an example?
Yeah.
Let's just talk weight loss. I mean, the hardest thing to do is to get people to understand how to get off crappy foods, eat decent
Yes,
stuff, lose
exactly.
20 pounds, and change your glucose.
Okay, so these are some examples from actual coaches working with patients who understand this patient is at the beginning. They don't have good mindfulness or self-awareness yet. They don't have some of those very basic foundational skills. So pay attention. How often are you eating junk food or fast food? How often are you taking the stairs at work? So you start with small steps that are achievable. One coach said that she contracted with a patient who wanted to lose weight, who had all kinds of problems. What she thought she could do in this direction was to cut down from 12 donuts a day to 7 donuts a day, and that was a victory for her. It was a first small step.
And a doctor would be so dissatisfied
And measurable. There's data there.
with that. But we have to be satisfied with
But
that.
I mean, you're right. A doctor would not be satisfied with that, and that's what I'm saying.
But you know, it's a very interesting hurdle because you know, you and I are both going, seriously?
Yeah.
But you're right. That is a very measurable and honorable, I would almost say, step where someone should get a lot of encouragement saying, way to go, instead of saying, seriously?
Yeah.
It can't be zero?
Yeah. Well, and
It's
that's
also honest. I
Because
mean,
there's a lot of pejorative, I
honest.
mean, you know, we're good at being judgmental.
So now the thing, the problem is that that's a good measure for her. That matters to her, and it's honest in terms of what she thinks she can do. But what's the physician going to be measured on? The A1C.
Yeah, right.
So the A1C is not going to change, and they're going to get some sort of disincentive or some sort of sort of quality measure that's not going to be good for them. But you know what? Maybe that's not the right overall measure for the population of people with diabetes who are trying to make changes.
Right.
Maybe we need to have some sort of composite that takes the patient-reported measures that matter to them, add them into something that we're doing clinically in a biometric measure, and then figure out where's the right measure and what's the right incentives to be giving people.
So one outcome we could think about is, are people gaining in their ability to self-manage? Are they feeling more in charge? Are they feeling more empowered? We can measure that, and we're actually looking at this now with the patients of different doctors. And guess what? Some doctors are better at supporting gains in this than others.
Right.
So we could reward that.
It's very interesting. We've been measuring all the wrong stuff. Yes, question way back up in the back.
We're prioritizing all the wrong measures. We're not measuring
There
the
you
wrong
go.
stuff.
There you go.
I'm Jean Tang. I'm one of the Mayo Clinic pediatric subspecialists here. So just going back to the concept of labels and terminology, I personally hate consumer because there's a pejorative term that we use in physician language called doctor shopping. And that's not actually used by us in a positive context. And so that, for me, is actually a grading term. I'm a pediatrician, so I have a demographic where I'm particularly interested in patient activation. I work with teenagers, and they go on to be in their 20s. We are in the era of helicopter parents who want to do everything for their 20-some-year-olds and even 30-some-year-olds. We are working with populations that are transient and mobile, and it's great that they are very connected on the internet, mobile devices. But is that enough? And how can we reach this particular demographic? Because no offense, they're not necessarily watching you guys on TV.
Yeah, no, listen, and I think it goes back to your point. I mean, how do you take an 18-year-old who thinks that death is an option, and certainly nothing in the foreseeable future, but still has to, if we're really going to talk about responsibility, start to know waist circumference, blood pressure, peeing in a cup occasionally to see if there's any sugar or protein in it. and that gap. And so, of course, everyone's been saying, well, there's an app for that, there's an app for that. Well, I don't know what you do with all those apps. I don't know how you sort of bridge the gap. And you know, my hope has been that one of the great things with the Affordable Care Act is that we've been able to keep our kids on our insurance until they're 26. For me and for my children, that has been wonderful because I've been able to sort of get them engaged with their own doctors and launch them. So before my kids were sexually active, I introduced them to a gynecologist and said, this will be your point of contact, and I stepped out. And I'm hoping that, and I think this is not helicopter parenting, but good parenting, that there is this increased transition period to introduce young, responsible 18, 19, 20, 25-year-olds saying, this is yours now. You have to run with it.
Right. I would actually even go further upstream, and that would be to start in the schools at the very youngest ages and really getting
Well, don't even get me started about what we're not doing in the schools.
But as parents, I mean, you know, I have this sort of vision. If I were to come up with what my TED wish it would be that every mother who conceives begins the health map for their patient, for their child right from that moment, and begins to ingrain the value of health, the importance of health from the moment of that child's birth, and follows that all the way through to the point where they do launch them appropriately, but they're ready to be launched with the feeling that health matters, and it's really important for me to maintain my health, and that it's not something that we take for granted.
So it's interesting you bring this up, because this is like another soapbox of mine. It makes me crazy that we aren't teaching health and wellness to kindergartners. I mean, why are we suddenly like teaching health ed to 13 and 14-year-olds who've already figured out oral sex? Too late.
Exactly.
This idea of knowing body parts and having ownership for it and thinking, you know what, mommy says the carrots are better and that's what you reach for in the cafeteria.
Right.
We're playing catch up when we already know biologically that heart disease has been laid down in 7 and 8-year-olds.
Exactly.
And lives have been foreshortened by the time kids are 15.
Exactly.
But we have to find the courage, and I think in our communities, to say, we're going to take the schools back. And regardless of where people come from in this country, it means we have to go back to science. And science and biology need to be a part of how we raise our children. And I fear that we've really become a scientifically illiterate nation.
I would agree. I have a 3-year-old grandson, and he is completely adept at using apps and using the iPad. There's absolutely no reason with the technology we have today that we can't start children out earlier with much better kinds of information and making those conscious choices as a society. And I think it was talked about before, we need a social compact that's really committed to being well and to being as well as you possibly can, and understanding that illness will come, but when it does, living as well as possible is really the collaboration of the communities you have surrounding you. And it's that collaboration that ultimately helps you to be able to have the resilience, have the resources, and have the kinds of just overall ability to be able to take on something that may now be taking more of your energy than it did before. So,
may we get a microphone way over here to the side of right to this gentleman, right up here. It's interesting that you go back to this idea of compact and changing the words, because it's the 3 and 4 and 5-year-olds absolutely have their finger on more and better information. And I don't
possibly,
know,
if we give them
if we give them right,
they have the tool.
and it has to be the right stuff. And and with all due respect to how people want to parent, and religion and social mores, I totally understand that. But I worry that kids don't get it until it's too late. Let me take this question and then back to you, Judith. Yes, sir.
Hi, my name is Joel.
And where are you from, Joel?
I'm from Boston, with a company that does medical second opinions. There's so many different things that you've talked about today that are interesting to comment on. But one of the things that I wanted to bring up, you were talking a little bit about someone who had 12 donuts and cut it down to 7 donuts, and how to evaluate that. I don't want to lose the process of, while we may be worried about, or we want to help them to get better, but what the measure is whether they improve their health. And if they're diabetic and we want to get their hemoglobin A1Cs down, we don't want to say that, yes, they've empowered themselves and they've done a great job if they haven't changed the outcome to some extent. So while they are taking a step in the right direction, they haven't necessarily gotten to where they need to go. So we want to applaud the steps, and we want to applaud the way they're going, but we don't want to say that is the outcome, and because they've decreased from 12 donuts to 7 donuts, they've achieved something. I mean, they've achieved something, but they haven't achieved what they need to get to. And in the same way, you were talking about the labeling and the language, and we have to find out the right way to talk about these things. But, you know, the patient relationship, or why we came up with the word patient, I think, originally was the relationship between the doctor and the patient, because there's something that's kind of unique or unusual about that. You know, a consumer goes into Target, but the consumer becomes a customer when they buy something. And the same way that the patient is a consumer, is a client, is a whatever, but when they have the relationship with a caregiver, there's a term for it. And I think that one of the pejoratives that came along with patient was that there's this concept that the patient is a physician-patient relationship.
Well, it's the trickle-down idea of trickle-down medicine. I mean, therein lies one of the problems with patient. I mean, and I don't think it was intended to be that, but when you are a patient, you are the recipient of information, and you're the recipient of guidance. You're not necessarily, it's nothing contractual. You know, you will help me. And you know, I mean, I come from a long line of physicians. I don't think it's ever been meant to be condescending, but it's sort of become that.
Yeah, right. Well, I think you raise a good point, because it is a special, I like to think it's a special relationship.
I do too.
It's a special, the thing that anyone would put their trust in me to help guide them on their health journey. So you're right, it's almost, I mean, priest parishioner may be a little too far, but it's that level of intimacy, I think, that is present. It should be present
And
there.
one of the things I believe, someone can correct me if this is wrong, but I believe in the late 80s, early 90s, the nursing profession kind of decided that the term patient may not be
And
the
I apologize
correct
for the
one.
crickets. That is my phone. So. You would have thought I would have turned it off. That's what happens when your 15-year-old reprograms your phone and then runs off to school. So.
But I believe that the concept was to recreate that relationship, because the term patient was kind of reserved for the physician-patient relationship, and the nurses wanted a different form of a relationship to be able to be part of the caregiving team. And I think we've never really resolved that kind of labeling process of what does it mean to be part of the caregiving process.
We need to just create a whole new word, don't you think?
No, I think it goes back to exactly what you brought up. Maybe we're just people.
Yeah,
I mean, maybe
people.
Maybe we just made it all too damn complicated. It's just
Exactly. When it comes down to it, it's life. It's life that's lived, and during that time, there's times when we're well and times when we're not, and we're just people in that regard. So.
Yes, sir.
My name is Tico Blumenthal from the Medtronic Shanghai Innovation Center, and I wanted to ask the question and then share a couple examples. So the relationship between physician and patient is special, but it isn't at the same time. You're trying to influence somebody, and everyone is trying to influence everybody else every day. So there's a tremendous, since the beginning of humanity, sort of history of how do you change somebody else's behavior? Whether you're the boss, whether you're the cop, whoever it is, there are tons of things that are great examples, and there's a lot of social psychology that is really pushing this. And I think, why is this special? And if we can understand that, I think it's possible to move a little bit farther in this journey.
That's a good point.
So 2 quick pieces that I learned at TEDMed. One is the best indicator of future performance is your own expectation of future performance. And so the dentists were actually figuring this out when they gave people a sort of a high fear and a low fear version of education. They told some people it's good for you if you brush your teeth, and then the rest of the people, they showed people with missing pieces of their jaw, oral cancer, a variety of different things that happen that are real scary things that happen from that future state. So they're selling you away from one future, and then they're also giving you some casual advice. And they found that that education had no correlation with what people actually did. It had to do with whether or not people said on a form, I think I can do something different. And that's the first piece.
That's
And
why
the
the
second,
7 donuts matters.
That's right. That's right.
the issue is, I think that's enough. So why is it special? Why is trying to change behavior special when it's the sort of fundamental human condition?
Well, so here's why I think the doctor-patient relationship is special. I think the doctor-patient relationship is special because in that moment of my 5 minutes, 15 minutes, or an hour, people confide in me things they might not confide anywhere else, and they look to me for an okay, for a hand-holding, and for guidance. As a cancer surgeon, I change people's lives, and not always for the good. 3 things you do every day that you take for granted. You swallow, you speak, and you breathe. And if you come to me with a head and neck cancer, one of those 3 things I'm going to alter forever and not for the better. So my job is to be your advocate and your friend and sometimes your boss and sometimes your mentor, but never to leave you for the rest of your life. That to me is a very special relationship. And the other thing is, everything you say to me never leaves the vault. I don't go home and talk about you. I don't even acknowledge your presence on the street if I run into you, because you have to know that whatever you have said to me, I will take to the grave. So that, to me, makes the doctor-patient relationship extraordinarily special.
I would fully agree with that, and being a nurse, certainly the relationships that I've had with my patients have been equally special for similar reasons and some for different reasons. But I think one of the things I would like to postulate and one of the things I would like to suggest in going forward is that we rethink that relationship and we acknowledge that there are other people that people are encountering that are giving them similar sorts of supports. Maybe not the kind of expertise that you're going to bring in terms of a cancer specialist, but as a person who's working with a person in the community and I'm their caregiver or I'm their coach, I want to be sure that I'm going to have that special relationship as well. And I think we all need to start thinking about fostering that. I think there's a certain dependence on the physician-patient relationship
I agree with
that overemphasizes that as being way too special and not enough on these other relationships.
And I
that we
agree
have
with
to
you. And
depend
so when
on.
I talk to you about my patient-physician relationship, it's not exclusionary of anyone on the team. It's that unless you say to me, you know, I assume that things will be talked about that you hold very close to the vest. And it's my relationship to honor that. But the good, you know, we've danced around this idea of person, consumer, et cetera. When it works well, the patient is at the epicenter. And it's the doctor, nurse, dietitian, family member, priest, rabbi, you name it. It's everyone, that person once in the wheel. It's access to good OTCs. But then we have to look at the human nature of it all. And if the person says, well, guess what? I'm still going to eat my 15 donuts. Do we as professionals give that person as much support as we do the person who says, I'm not doing any donuts tomorrow? And my feeling is, I wonder if sometimes we do walk away from people who don't try as hard. And so this is part of the human nature aspect of we can measure things. We know what a perfect system looks like. We recognize we live in an imperfect system. What do we expect of people? What do we expect of ourselves? And then at the end of the day, who's letting whom down? And I suspect on any given day, you get a different answer. It's complicated. It's complicated. But if we do anything other than leave here today, you know, recognizing that in some way we're all in this room because we all have a stake in this game, maybe the charge today is to go home to think about, you know, how you put so eloquently the term, the person. Everybody's going to engage differently. Those of us who are in the system don't always take good care of ourselves. We under-engage a lot. We know that women particularly access the healthcare system differently than men, and we, many times when we're caregivers, do not take good care of ourselves, and we give to everyone else until we are spent. But maybe today's charge is to think about what that term is. Maybe we ravel or unravel things, and we go back to basics. Perhaps we have, with our words, made things too complicated, and people just go back to being people.
I would have to support that. I think that we need to go back to understanding what is it that matters to us, how do we put that into perspective, and then how do we access what we need, and then be able to articulate that to the right person that we trust to help us get there.
Yeah.
Judith, final thought?
I guess my final thought is, as we move into this era where everyone is going to have more access, that we need to be aware of the needs of people who aren't right there signing up and very engaged and think about that. Those other folks.
I would just say I think the world has been sort of broken wide open at this point in terms of our ability to recreate what we call our medical system. This is the right time for us to push this culture forward.
Become self-disruptive.
That's right.
God knows you've been.
Are you going to embarrass him again?
KY jelly.
Why, you're probably responsible for more births than anybody in this room.
But I will echo what Judith said. I think it's access, and I just don't think it's access as we talk about it to the healthcare system or to physicians or to nurses, but it's also access to tools, it's access to new products, it's access to anything that can engage a person, anything that can engage you in your health and move you forward on a better track to wellness or to health, whichever one it is. And so I think access is the key.
All right. I want to thank you guys, fabulous panelists. Thank you all so much, and thank you, everyone.